Alright, let's continue with ventricular dysrhythmias. We will skip junctional dysrhythmias. These are not very common. I've never taught these in class because they're not very common. So I doubt if you'll get tested on these on the NCLEX either. So let's go straight to the ventricular dysrhythmias. Here they are, ventricular dysrhythmias, page 553. So the first one are PVCs. So just like in atrial dysrhythmias, when you had a PAC, you can also have a PVC. There are different variations of the PVC though. So by definition, premature ventricular contractions are, by the adjective itself, says premature. So these are prematurely occurring ventricular contractions. We're referring here because the ventricular contraction is represented by the QRS complex. So these QRS complexes are occurring prematurely. And one thing to note is there is no P wave visible prior to that PVC because the impulse again originated in the ventricle. Meaning if you look here, figure A, there is it is otherwise this one is sinus rhythm. Okay, so the patient has a sinus rhythm, and then all of a sudden a PVC appeared, okay, or a premature ventricular contraction, a premature QRS. And a PVC always looks distorted. See, this is your normal PVC here. This is your normal QRS. But as you can see, obviously this QRS is not normal. It looks distorted. Then after that, the sinus rhythm resumed until it occurred again. Okay, so this is, and since these two PVCs are look the same, that means they came from the same ectopic source. So this type is called a unifocal PVC right here. Figure A is a unifocal PVC. Another type of PVC is if they don't look the same. So let's say look at figure B. So this is sinus rhythm, and then you have a PVC that occurred looking like this. And then here, similar to a PAC, there was this compensatory pause, if you notice. Okay, so after this PVC, there's a little pause, and then the normal sinus rhythm resumed until it occurred again. So here, there's no P wave, and then you have a distorted PVC. But obviously, look at this. These two don't look the same. So this one obviously came from one source. This one came from another source. Where? We have no idea where. But we just know that they are, the impulse originated in the ventricle because these are QRSs. But because they are premature, they don't look normal. Okay, meaning these QRSs here came from the same electrical impulse that came from the SA node. Meaning the SA node fired, and then that same electrical impulse reached the AV node, and then that same electrical impulse was passed on to the ventricles, resulting in this normal QRS. Here, the same thing, normal QRS. So here, obviously, there's no P wave, right? That means this electrical impulse that generated this one did not come from the SA node. This one came from somewhere inside the ventricles, okay, which generated this impulse. That's why it's called a PVC. And this particular type, again, these two don't look the same, so they came from two different sources. This is now known as a multifocal PVC. Okay, coming from two different sources. These two again are the same PVCs, so only one source is generating these impulses. Again, it's not coming from the SA node because there's no P wave preceding it. Okay, unlike these two here. Another type of PVC is these two occur the same. So just like this one, they're the same, but however, they occur in succession. So if you have two of them occurring, or one right after another, then that is called a couplet. Okay, so here C is now a couplet. Okay, meaning you have two identical PVCs occurring in a row. And if they occur 3 times, okay, so there's a three-peat here, then that's called a letter D will be a triplet, or a three-beat PVC. Okay, so a PVC can be unifocal, multifocal, or this one is double, so we call that a couplet, couplet, and then 3 in a row will be called, and then they look identical, this will be called a triplet. If they occur alternatively, so instance in figure E, these PVCs occur every other beat. So you have sinus here, and then a PVC, sinus, PVC, sinus, PVC, sinus, PVC. So since it's occurring every other, then that's called a bigeminy. Okay, that's called bigeminy. Same thing here. So you have this one, by the way, is not abnormal. This rhythm here is just taken from another lead, usually from any of the chest leads, probably V3 or 4, 5, or 6 leads, the chest leads, because the leads are looking at the heart from the bottom, so that's why this QRS looks inverted, okay, because the lead here is just viewing the electrical impulse at a different angle, okay. But this is a normal QRS, but the lead here used is just from another angle, okay. So these are your PVCs here. So again, sinus, PVC, sinus, PVC, sinus, PVC. So it's occurring every other, so this is called a bigeminy. Now letter F is called a trigeminy because this thing is occurring every 3 beats. So you have here sinus, and then PVC, and then here's the compensatory pause, and then you have sinus, PVC, pause, sinus, PVC, compensatory pause. So this is called a trigeminy. So same thing, these are all PVCs, different variations. However, regardless of the type of PVC, unless the patient has symptoms, they are typically not life-threatening. These are your causes: hypoxia, MI. PVCs typically occur during an MI because the patient's ventricles are injured, so they're very irritable. They typically develop PVCs during an MI. Here's cardiomyopathy. CM is cardiomyopathy. Electrolyte imbalances, usually potassium imbalances, whether it's hyper or hypokalemia. Here's coffee again, hypertension, and recreational drug use, which is usually a stimulant, like cocaine or whatever you guys are taking. Treatment for PVCs, again, based on the symptoms. If the patient is symptomatic, then we will give drugs. Otherwise, the treatment for PVCs are to treat the causes. So if you identify and see you look for and identify the causes, and once identified, then you treat them, and that should eliminate the PVC. All right, the next two are serious dysrhythmias. The next one is ventricular tachycardia, V-Tach. This is now multiple. It can be a run of 3 or more PVCs. However, this will severely affect cardiac output. By how much depends. So V-Tach is life-threatening. So V-Tach can either be V-Tach with a pulse, right here, V-Tach with a pulse, or a pulseless V-Tach. So therefore, if you ask on a test question, what do you think will be your first action when you see a patient with V-Tach, right, like this? Obviously, your answer will be to check for a pulse, or at least check the patient's vital signs. Of course, if they're pulseless, then you won't see any vital signs. Okay, but as long as the patient has a pulse, then you will see blood pressure and heart rate. These are the known causes of V-Tach. Again, the same causes, whether it's V-Tach with a pulse or pulseless V-Tach, the causes are the same. It's just a matter of whether or not the patient is tolerating the dysrhythmia. Obviously, if they're tolerating it, then the patient will have a pulse. If not, then they won't have one. You will have a table, again, a summary, just like for atrial dysrhythmias, it's found below. But since we have the interventions here, so here they are. But I'm just telling you that there is a summary. Okay, there's a table summarizing all the ventricular dysrhythmias later below. Okay, so V-Tach with a pulse, the patient obviously is the V-Tach is pretty stable. Okay, the patient is having a pulse, so there is cardiac output. Remember, pulses are found not only in the carotid but also in the radial or even in the feet. Although those pulses will be faint, very weak, but at least blood is reaching those parts of the body. So that's why you have a pulse. If they have a pulse, then these are your treatments. Treatment options are amiodarone, or like I said, since these are the causes right here, then you treat these causes, okay, if there is a pulse. Now, pulseless V-Tach, this is treated the same way as ventricular fibrillation, meaning the patient has zero cardiac output. So therefore, first action is to do CPR. Of course, you already checked for a pulse, so obviously you realize that it's a pulseless V-Tach. Then you start, of course, call a code and then start CPR. And then after that, of course, the patient will do full ACLS. Again, the details of the interventions here are in the table. Okay, but here do CPR. And like I said, V-Tach with a pulseless V-Tach is treated the same way as ventricular fibrillation. Therefore, the patient will receive defibrillation. All right. So again, defibrillation is not the same as cardioversion. So the only drug here used for V-Tach with a pulse, the preferred one is amiodarone. And as mentioned, other treatment will be to treat the other causes here, depending on the cause. Whereas pulseless V-Tach, again, the patient doesn't have any cardiac output, so we treat the patient as if they are in ventricular fibrillation. So therefore CPR and then defibrillation. And of course that will include epinephrine, atropine, if indicated, and then amiodarone also, part of ACLS. Ventricular fibrillation. This is another life-threatening dysrhythmia similar to pulseless V-Tach. So this one, there is no, look at the rhythm, there is no organized rhythm. It's very chaotic. So obviously there are no P waves, no true ventricular contractions because there are no QRSs. So there is no cardiac output here. So the patient will receive CPR, and these are the causes, really the same as in V-Tach if you compare. Okay, it's exactly the same. Here's your treatment. So of course you call a code, start chest compressions, and then defibrillate. Medications here commonly used are epinephrine or vasopressin, then amiodarone, atropine, right? The rest here are reviewing your CPR. It is testable because everybody should be masters of this, or so we expect, because you are BLS certified. You all have your CPR cards, so yeah, so this will be tested on how to do CPR. And as I already mentioned, the medications are either epinephrine or vasopressin. Okay, these are the doses. And then after that, we give amiodarone. Okay. And I mentioned this earlier. So since we are defibrillating the patient, make sure you clearly shout that, loudly shout that is everybody clear, all right, before you press the buttons on the paddles. We will skip idioventricular rhythms. We'll go straight to asystole. Okay. The reason is, again, these are not very common. You'll see pictures here. So these are idioventricular rhythms. So we'll only test asystole. Okay. Right, asystole meaning no measurable electrical activity. Okay, there might be runs like this because this thing here, figure C, is still called asystole. This is still considered asystole, but however, there is no measurable electrical activity. Here, so the possible cause of this is just this one. So it may be a loose ECG patch or wire, so that's why you have this maybe, okay, but those are not measurable electrical activity. Obviously there's no pulse, so asystole is only treated one way. You do chest compressions and then you give ACLS medication, epinephrine, vasopressin, atropine. Obviously atropine is given. There is no defibrillation indicated because there is no rhythms. Okay, so you cannot defibrillate a asystole, right? Defibrillation is not indicated because what are you can only defibrillate either fibrillation, ventricular fibrillation, or pulseless V-Tach. Okay, those are the only two rhythms that you defibrillate. Asystole, no, because there is no rhythm to defibrillate. Alright, and that's the last of the ventricular dysrhythmias. Before I go to heart blocks, I just want to point out here is your summary, table 29-0.6. These are the summary of your ventricular dysrhythmias. Again, they differentiate. This is spoon feeding already. You guys are very lucky. The author created this. When I went to school, we had to create our own from the paragraphs. We had to make our own table. So yeah, there's no reason why you can't ace this next exam. All right, so the last dysrhythmias are heart blocks. What are heart blocks? Remember we said that all signals come from the SA node, correct? So if it's a sinus rhythm, it comes from the SA node, and that same signal, electrical impulse rather, is sent to the AV node. And then we know that the AV node does not transmit it immediately, so that's why we have a PR interval. So the PR interval is a pause, right? It's a delay which allows the ventricles to fill with blood first before that same electrical impulse is sent down the left and right bundle branches, and then consequently the ventricles will contract. So again, this is very important, the PR interval, that the AV node is in charge of that. So again, this impulse is the electrical impulse is generated by the SA node, and that goes straight to the AV node. However, the AV node will delay that transmission. It will hold on to that electrical impulse by 0.12 to 0.2 seconds before that electrical impulse is transmitted down to the left and right bundle branches. Okay, so in heart blocks, there are four. Technically there are three. There's first, second, and third degree. However, there are two types of second degree. There's a type 1 and a type 2 second degree block. These are the causes. So regardless of the heart block, whether it's first, second, or third degree, they all arise from acute coronary syndrome. If you remember acute coronary syndrome, there are three. We have unstable angina, then we have STEMI, ST elevation MI, and then we have a non-STEMI or non-ST elevation MI. Okay. In first degree heart block, as defined here, it's technically normal sinus rhythm. However, one or more of the PR intervals are prolonged, meaning they are greater than 5 big blocks or more than 0.2 seconds. So here's your picture here of a first degree heart block. So obviously this one, a normal PR interval should only be 5 small blocks or 1 big block. Okay, that should be the length of, but clearly here, this is our PR interval from here, from where the P started to right before the Q started. So this is your PR interval. It's obviously longer than 0.2 seconds. Okay. So since it's first degree, and stated here, there is no treatment. You just identify the cause. All you do is really notify the doctor that there was a first degree heart block, and then you try to identify what could be causing this. Sometimes it could also be caused by digoxin. So this is another dysrhythmia caused by digoxin. And then the doctor may consider either holding it or maybe changing the dose of the digoxin, maybe. Right, so that's for first degree. Again, typically this is as stated here, it's very rare that the patient is symptomatic for a first degree heart block, particularly with this example we have here. This one, the heart rate is still 60. So 1, 2, 3, 4, 5, 6. So this patient has adequate cardiac output. So I doubt they'll have any symptoms for a first degree heart block. The second degree heart block, as already mentioned, there are 2 types here. There's type 1, which is also called Mobitz 1, and then we have type 2 or Mobitz 2. In type 1, the problem here is not only is in type 1 there was a one or more PR intervals that are longer than 0.2 seconds, right? Now here in second degree type 1, the PR interval gets longer and longer and then dropped, meaning you have one missing QRS complex. Okay, so look at here in figure 29.28. So here, this is a PR interval. We need to have no longer than 0.2 seconds, right? So this one is 1, 2, 3, 4. This one is okay. This is still 4 small blocks. So this PR interval is normal. However, look at the next one. It got longer and longer. So this one has 6 small blocks now. So this is now 0.24 seconds. And then this one is, I don't know, 1, 2, 3, and then 5. So that's 9 times 0.04. So this is 0.36 seconds now. So clearly here you have gradual prolonging of the PR interval, and then finally you lose a QRS. Okay, there's a missing QRS here. Right, so this is now obviously the patient may have symptoms now because the patient's heart rate will be considerably affected because now you're losing one QRS, and this is only in a 6-second strip. Okay, so you probably lose another one in the next 6 seconds, and then so on and so forth. The way to remember this is you can compare heart blocks to relationship. So in first degree, it's no big deal. So let's say me and my girlfriend, when we have a date, so in first degree heart block, I show up late. Okay, I show up late, but I show up nonetheless. So our relationship is okay. So we have a good cardiac output. So in second degree type 1, in every date that we have, let's say we go out every weekend. So this weekend I'm late, the next weekend I'm even later, and then the next weekend it's getting worse, and then the fourth date I stand her up now. Okay, so that is now second degree type 1. In second degree type 2, oh, by the way, a treatment, because again the patient's already symptomatic here, the patient will be given atropine, because again this is only what you're looking at here is only 1 6-second strip. So definitely if this is now times 10, the patient is losing quite a bit of ventricular rate now. So the ventricular rate here slows, which will of course affect cardiac output. In second degree type 2, as mentioned here, this is more alarming and potentially life-threatening, because this type will now progress to the third degree, which is the worst type of all the three. So this is what happens now. So this is now type 2. As you can see, the peer interval doesn't necessarily get prolonged, unlike type 1, but now you're dropping more than 1 QRS now in let's say this is a 6-second strip, so you're losing more and more QRS complexes. So the heart rate here is considerably lower. So take a look at this one, for instance. So this one only has 3. So the heart rate here is definitely in the 30s, maybe 40 if you're lucky. Okay, so the second degree type 2 is worse than the type 1. Right? So if you have a low heart rate here, low cardiac output in second degree type 1, that will be worse in second degree type 2. So definitely the patient treatment here, besides atropine, because usually atropine doesn't work for this anymore, the patient will need pacing now. Of course, we can't just call a cardiologist, cardiac surgeon to come in and put in a pacemaker at any time of the day. The patient will receive a temporary pacemaker. So we will use transcutaneous pacing. We will have a table shortly with your nursing responsibilities and a description for each one. So this is the fastest pacing option. So you can just slap this on the patient. So this is like putting on an AED on the patient. Okay, you just put what is this? Pads. Yeah, you put adhesive pads on the patient, and it will begin pacing the patient. So in heart blocks, the SA node is firing, okay, whether it's first degree, second degree, or third degree. The SA node keeps firing. As you can see, there are P waves here. In first degree, there are P waves. In second degree type 1, there's P waves. Second degree type 2, there's P waves. Even in third degree. So in third degree heart block here, there are P waves. However, the degree by which it is blocked, so somewhere between here, between the atria and the ventricle, somewhere here, that signal, this electrical signal, somehow is not getting to the AV node. Okay, so as a result, remember the AV node is a pacemaker itself, and the only difference between the SA and the AV node is SA node fires between 60 to 100 electrical impulses a minute, whereas AV node fires between 40 to 60 beats a minute. Okay, so as you can see in heart blocks, if the AV node doesn't receive the electrical impulse coming from the SA node, it will generate its own electrical impulse because it is a pacemaker. Right? That's why it results in bradycardia. in all types of heart blocks except for type 1, of course. Type 1, you have no dropped QRS, meaning the signal is still getting to the AV node. It just came late. Okay, so in type 1, the electrical impulse reached the AV node. However, it reached it late. Okay, so that's type 1. In type 2, some of the electrical impulses are now not reaching the AV node. Okay, some of them are getting lost. We don't know where they went, but somehow it was blocked from reaching the AV node. Here is the pacemaker I mentioned a few seconds ago. There are different types of pacemakers. This one obviously is a temporary, or we call them also external. External pacemakers are temporary pacemakers. Then we have internal pacemakers. Of course, these are now permanent pacemakers. They're just comparing the how they function. But the questions on exam will be teaching the patient, what to do with internal pacemakers, because this is what they go home with. Okay? It is surgically implanted. We'll get to those shortly. Let's finish the heart blocks first. So the third degree heart block is the most serious, meaning what happens here is the SA node fires electrical impulse, but since none of them, literally none of those electrical impulses are reaching the AV node. So therefore, the SA node has no idea, by the way, that the electrical impulses are not reaching the AV node. Neither does the AV node know that the SA node is firing. All the AV node knows is it's not receiving any electrical impulse. So therefore, in third degree, you will have a different atrial rate while having a different ventricular rate, but all of them will be regular rhythm. Look at this rhythm, for instance. These are your P waves. So that means this is your evidence that the SA node is firing, because you see P waves. And if you have a caliper, or your poor man's caliper, if you measure these are actually occurring in a regular rhythm. Whereas, look at your ventricular rate also. If you measure from this R to this R, and then from this R to this R, it's actually regular also. And then from this R to this R, these are regular. Meaning, in a relationship, obviously there is no relationship. Me and my girlfriend have already split. Meaning I'm going my way. So let's say I'm the P wave. I'm going my way. And my girlfriend is also going her way. So we are not talking anymore. So I'm generating, if I'm the SA node, I'm generating my own impulses. And then the AV node is also generating its own impulse. So obviously, since the SA node fires 60 to 100, so your atrial rate is anywhere between 60 to 100 beats a minute. And while the AV node can only fire anywhere between 40 to 60, you have a considerably lower ventricular rate. Okay, so this is a complete heart block, meaning you have a complete AV disassociation. That's another term for this, is AV disassociation rhythm. Okay, meaning they are not talking to each other anymore. There's a complete heart block. The SA node electrical impulses are not reaching the AV node. So therefore, as a result, the AV node has to generate its own lower heart rate, resulting in this type of rhythm. And for this rhythm, there's only one treatment. You just put the patient on a pacemaker. Okay, external first until the patient will receive a permanent pacemaker. Here are your nurturing interventions now, regardless of the patient's dysrhythmia. Remember, our number one concern is cardiac output. So here you have checking vital signs. How is the patient tolerating the dysrhythmia? Again, the interventions will be specific to each one, starting from atrial dysrhythmias to ventricular dysrhythmias to heart blocks. Okay, so you're in charge of studying the drug therapy and your responsibilities for each of those drugs, right? So again, our rule is always look at the patient first. Okay? Don't go for the monitor right away. Assess the patient first, equipment or the monitor next, right? So just go down this list here. You can read. You've graduated high school, so I expect you to be able to read and understand these signs and symptoms. Here, obviously, as we mentioned last week, if the patient is symptomatic, there will be signs and symptoms of low cardiac output, starting with your vital signs. And then there's a change in LOC because obviously there's not enough blood going to the brain, so therefore the brain doesn't receive oxygen, so there's hypoxia there, right? And then it tells you really here, so what's the cause or the rationale for each sign and symptom. Okay, so please read them. Oh, by the way, if the patient has a pacemaker, so since it's not SA node anymore, so you won't see P wave. Instead, you will see a pacemaker spike. Okay, so since it's the pacemaker now that is generating the impulse. Okay, so that's what we call a pacer spike. So the patient has a paced rhythm now. Again, these are not abnormal, okay? These QRSs are just seen from a different lead on the cardiac monitor. That's why they look like that, but these are not PVCs for any reason. Here's a summary of heart blocks. Okay, it's table 29.8. And here are your actions for dysrhythmias. So anti-dysrhythmic therapy will be depending on the dysrhythmia. Again, look at table 29-0.1 for each of those, and especially the nursing responsibilities. And here are your teaching, and I don't know if this will help you. Well, we did memorize the numbers last week for PR interval as well as the QRS. I don't know if you want to study it this way or just look at the sample pictures. Okay, it's up to you if you'll use this to interpret the rhythm. But like I said, I will only use the rhythms, the rhythm strips that are on your textbook. And that's it.